Next, we have the pleasure of listening to Josh Michelson, partner at Oliver Wyman, who does some fantastic work in health consulting. He's out of the Chicago office, and he specializes in transformational business strategy, design, implementation, partnering with health plans to move to value-based care. So with that, please welcome Josh.
So the first thing I'll say is I'm in a boot, and my option was actually about a month ago. I was going to go skiing this weekend or present to you guys. And some version of fate, the gods, and my wife intervened, and I'm here as a result. So she's probably happy that I'm not on a mountain. But it's really a pleasure to be here, and I'm actually going to pick up on a topic that the last group was discussing, which is what happens in the world between payers and providers. So I spend most of my time working with health systems, thinking about their business model transformation. But increasingly, as the world kind of plods along, providers and payers are needing to come together in different ways. And I've had the pleasure of also sitting on the payer side of the house and seeing how the blue plans and the big nationals are thinking about that. So before I came to this conference about a week ago, I closed my eyes. I'm going to ask you to do the same, which is when you think of a payer-provider partnership, what comes to mind? And this is what came to mind. I grew up in Boston, and so this still, 13 years later, holds an impression. So we have had a history of tenuous relationship, right? So that trust factor is real. And it's not just trust, it's actually the mechanism by which payers and providers have come together. The way they've come together is transactional base rate negotiations, right? And those are the people that have been in a room talking to one another, both about fee-for-service rates as well as value discussions. And that's a very difficult dynamic when you have the same people in the room. So what I'm hoping to do, by the way, I'm curious we'll get a poll of what your images were. Maybe it's the same, maybe it's different. What I'm going to try to do is share some of the early movement away from this kind of transactional and tenuous model. And I'm going to do it in a way where I'm kind of describing a spectrum of partnership models. And then at the end, I will share my thoughts on what might come next, and 100% of that has the possibility of coming true. I have no idea how much of that, but we can debate that together. One thing that's interesting, for me at least, is when you kind of put yourself in the shoes of the consumer, not the provider or the payer, who does the consumer trust, right? And actually this affects the relationship, because the way we've constructed healthcare is we have a payer value chain, right? A payer value chain pooling risk and pricing and benefit design and so on and so forth, some care management, and a provider value chain, which includes care delivery and condition management and things like that. But if you were to ask who consumers trust, it's very fractionated, right? So consumers at some level trust plans for certain things, in terms of finding coverage. They'll trust providers for other things in terms of getting care. Neither of them really want the provider or the payer in their life, which is very interesting because that's where the innovation is right now. How do you engage the consumer? So when you take that equation and think about, well, what is the purpose of the relationship, you have to ask yourself, why is the provider and the payer coming together, and how do they do it in a way to reinforce consumer behavior and trust, which has been an issue. The other macro environmental situation that's occurring that's probably apparent to any provider and payer in the room is that we have a major cross-subsidization problem in healthcare. A major cross-subsidization problem, which I think of as a Robin Hood effect, right? So you have commercial rates covering for most providers 140% of their costs, right? It is the center of the profit model for the provider and the payer. And so what's happening right now is, based upon where Washington goes, right? We've been seeing downward pressure on Medicare and Medicaid. There are proposals in place that would like to take that even further down. Right? If you take that and you kind of intersperse the fact that we actually have not made great progress from an affordability standpoint, and you then look at what might happen from uncompensated care, right, that will create even further upward pressure on commercial rates. And so we're in a situation where we're trying to kind of keep rates down, but employers are kind of feeling the brunt of this. And how are you solving for a situation where providers and payers are trying to preserve their profit on commercial? Everyone's kind of incentivized to do the right thing on Medicare, Medicaid, and the exchanges. That's a very difficult dynamic. And we haven't made a lot of progress on affordability. If you were to look at this from the standpoint of the employer or the employee, employers did a lot in the way of cost shifting, right? So on a per employee basis, they started to feel less and less and less. But because of that kind of pent up situation, the rates have now started to rise back up. So we have been seeing perpetually 6-7% growth. It went down to about 2% growth, but it's now back up. All right, so that's the backdrop. So with all of that kind of negative backdrop, I actually think there's a positive story, and we'll kind of share with you what I'm seeing in terms of a new era of partnerships emerging. And when you think about this, we're not new here, right? In the 80s, we had indemnity models moving to kind of rise of rich PPOs. We had a national model around DRGs. But by and large, this was kind of a fee-for-service model. In California, you started to see some HMOs coming into form. You saw even further HMO penetration in the 90s with a gatekeeper model. You had a proliferation of that, certainly in California. You had some very successful IDNs and staff-based HMO models. But in the rest of the country, it didn't quite work out so well, so congratulations, California. And so that then led to a world in which the 90s, which was really about kind of, brute force rate negotiations. And that was our story. When the ACA was passed, the government actually led, there has been a forced march to value, at least up until a month ago, and we'll see what happens moving forward. And so the government led innovation, right? It was a testing ground, as Michael said, for alternative payment models. And what I've observed in the last few years, kind of from 2015, is that the private market is starting to figure this out. The private market is actually in some ways moving past the government and exploring not just different payment models, but very different types of arrangements, and we'll describe that. So why partner? We had this spend equals price times quantity issue. Well, a lot of the partnerships early on were actually focused on containing price, unit cost. And the issue with that is we saw narrow, skinny networks developing, right? So we're going to trade network access volume for price, a discount. And in the end, I'm not sure that actually delivered a better value proposition to the end customer, but that was a way to kind of ramp down unit costs. I view that as different than total cost and value. I view that as different than the triple aim. And so we had a kind of, and that's not to say there isn't good rationale around reining in costs, but that has to be done, at least in my view, in the context of the right side of this page, which is improving total cost of care, which is about lowering the total number of units and actually creating differentiated value. And so left side, in my view, if you kind of run this out as a provider, is the race to the bottom. It's a race to commodity pricing. It's very hard to persist. The right side is where I think the source of many partnerships are evolving, particularly around value-based care arrangements. I'll describe a little bit more. The area that's coming around the corner in kind of the last year or two is the idea that it's not just about total cost and value, it's about the experience. And so as a provider and a payer, if you go back a few pages, we had that trust issue. How do you actually deliver a seamless experience across that entire consumer's journey in a way that a provider couldn't do and a payer couldn't do? So I think there's some very interesting things here. And then the last one, it's very nascent, but this is where I think the market needs to go, which is wear the hat of improving total community health. You have a provider and a payer that happen to be probably the largest employers in a market, right? What could they do together to figure out the social determinants model when only 20 to 25% of healthcare improvement comes from medical care? So we've started to see some of that, but by and large, the action has been in kind of the top right, and some more innovative models sitting down in the bottom right. As consultants, we like frameworks, so I apologize for this in advance, but what I did here is took this page and just arrayed it along the x-axis. and then thought about kind of the level of integration or collaboration that's occurring between payers and providers. So as I said, this transactional unit cost story is narrow, skinny network, right? That's not to say that there isn't a place for that, particularly for low-income environments, and you're seeing a lot of that with the exchanges. But the next few kind of get interesting, right? So you have value-based contracts oriented around some version of total cost and care. Some of those can still be transactional, right? So Ahmad and others in the last group were saying, well, data sharing is really hard. Well, if you're sitting in the opposite side of this table and you're trying to optimize your own sharing arrangement of that or your own gain share, and you're protective of your data, well, that feels very transactional, but there are models in place that are starting to look a lot more collaborative, which we can talk about. And then there's this kind of next wave of what's occurring. And this next wave looks different. It's not just we're going to delegate risk. It's actually we're going to try to create something together. So we have seen value-based networks or ACOs, which are actually multiple providers coming together with a payer and creating kind of a new network for consumers. We see a lot of co-branding, right? Co-branded products. We're going to put a product and wrap that around a health system and try to lower the cost of care and improve the experience as a result. And we've seen very interesting joint ventures. So a provider and a payer coming together and actually creating a new co towards some end. In some instances, that's been a health plan. In some instances, that's about actually creating something new from a care delivery standpoint. And then vertical integration. So you have the most classic vertical integration story in American healthcare and Kaiser in your backyard. But there are other examples of how providers are getting into the health plan business by buying plans, and plans buying providers, and that starts to take on a new dynamic. So at least for me, this is kind of the world in which we're kind of oriented right now. Some history here, a lot of action between 2010 and 2015 here. We're starting to figure this out, a little bit more commentary. This is where I think the next wave of change is going to come, and then hopefully in 10 years' time, we're kind of working on the right side of this page. A quick couple comments on value-based contracts just to build on what Michael said. So first of all, 95% of ACOs are in upside-only gain shares. That's a problem. That's a problem because an upside-only gain share is based on fee-for-service, right? So we are still proliferating ACO models that aren't really value-based contracts. It's like kind of light, get some bonusing, get some P for P. If you're a hospital system, maybe get some bonus dollars, but it's hard to kind of turn the ship around when that model is still oriented around fee-for-service. So a couple comments. First is, when I live in this world of value-based care arrangements, I'm not sure that the providers and the payers have actually identified a destination. They're going to kind of get into it, see how it goes. I think anchoring around that destination is actually pretty important, and actually being very explicit early on around what your glide path is to risk. Are you anchoring around something in 3 years' time where you're going to move there, or are you going to say, well, let's see how it goes for a few years? I think what we found, and this was part of the results that Michael shared, the earlier you get into the risk, the better off you're actually going to be a few years down the line. It actually takes time to get there. And the stability of the populations you contract on matters too, right? Getting into an exchange population early is tough. It's tough because the ability to actually understand what that population is, you don't have your arms around it as much. This is where a lot of value-based contract deals kind of break down in my view, which is everyone's trying to win, but no one's trying to win together, right? You have rate discounts as a price of entry, which we talked about. And then it's odd to me that when you have kind of CMS attribution models, a provider can make money on a Medicare shared savings program, but lose money on commercial. So that provider is doing the right things, but we saw in the case of Banner, right? Banner in Phoenix was one of the largest gain shares in the country, but if I'm not mistaken, just saw a public announcement about them losing money on their commercial ACO. So normalization of that attribution model and the benchmark setting has been complicated. This notion of harmonization, right? So we heard in the last group, well, providers dealing with multiple risk contracts, no one's on the same page from a metric standpoint. The government is coming in with quality. So how do you do that, right? And how do you actually deal with that from an operational standpoint? The other issue we often find is that there's a free rider effect, right? A payer is worried or a provider is worried if they get into a risk deal, right? That others, if a payer gets into a risk deal with a provider, then other payers are going to benefit. And so how do you kind of work through that if not everyone's operating at the same speed? And then certainly data sharing. I've spent too much time in my life in negotiations dealing with this one, reconciliation and trust. From a data sharing standpoint, real quick, as a provider, why are the reasons that you want data? There are 3 reasons you want data, I think. One is to figure out how you're doing in terms of managing the cost of a population, right? The health management side. A second reason you want it is so you can actually figure out what you're doing from a network management side. So you have employed docs, you're gonna wanna make sure you do the right thing to reduce your MLR, but are you actually constructing the right set of partnerships in the community with the right physicians and managing your network and your referrals? And you need to figure out reconciliation. And then on the payer side, they're saying, well, I need to protect the privacy of my members. And so that has to work itself through. And then the biggest issue for me when I think about what's happened from value-based contracts is that have they actually delivered impact, right? And there are 2 reasons that I don't think they necessarily deliver the impact we need. One is there's this pay and pray model, right? I don't know if anyone's done that here, I hope not, but we're going to delegate risk. We're going to hope the provider can work it out, right? Well, has the provider done the underlying clinical transformation that they need? That's pretty hard. Have you reconciled between the payer and the provider what roles you're going to do, and how are you going to get out of the duplicative roles? That's really hard, right? And there's a ramp on what so if you're a Caramore or an Iora, right, or a Landmark, and you're purposely focused at an upper crust of that population pyramid, it's a little easier with really good work to take cost out. If you have a more distributed population and you have a peanut butter approach, it's really hard, right? And it takes time. It could take 2 or 3 years to actually come out the other side. So, building that into how you think about it is important. All right, now let's get to some of the things that are occurring. So there's a second wave of partnerships, as I mentioned. And I won't have time to go into all of these, but some interesting ones. So Benevera Health in New Hampshire is a partnership between Dartmouth Hitchcock and Elliott and Harvard Pilgrim. And they're basically taking their assets and purposing those at much more intensive care management in an ACO model. And so those are competing health systems that have come together and said, we're going to do something together in the interest of the population. Banner and Aetna had formed a JV'd ACO. They are now taking that to form actually a joint ventured health plan in Phoenix. So they've said, you know what, we've been able to realize gains together, but we think we can go one step further and create greater stickiness with our members. We've seen co-branded products. So Together Health is a partnership between, in Michigan, Trinity, Ascension, 2 big Catholic competitors, now the University of Michigan, and they've formed a network, and they are partnering with providers. So they've partnered with Blue Cross, Blue Care Network on an MAHMO. And what's interesting here is that up until this point, I had not seen too many instances where mega providers were willing to kind of do a dance with a mega payer, right? In most instances, you're the big player in town, you're gonna ride out your market share position, as we said, and play defensive posture. But in these instances, they're saying together we actually are touching 75% of the population in Michigan goes through those systems. What can we do big as big, not in a defensive posture position? So I think that one's pretty interesting. Over in the top right, I'll hold off on Mount Sinai and Oscar because I'm going to get into that a little bit more, but we're seeing the creation of joint venture newcos to create something different. So Tandem, I'm sure as everyone is familiar with, it was a partnership between DaVita Healthcare Partners and IBC in Philadelphia, right? They went more towards the kind of down market primary care physicians. They believe that they could impact more care by working directly with the physician organizations, as kind of Michael was alluding to. So they created effectively an enablement organization to work against those or work with them. And then the only other comment I'd make is that we're seeing some interesting moves, in particular by United or United Optum, around getting into the care delivery business. And so, are we going to see a proliferation of kind of Kaiser 2.0, and how does that look like? And if you have Optum's assets, its insights, its IT platforms, its care management platform, can you actually deploy that at a different kind of scale point? So this is kind of the myriad of action that's occurring. And And just a couple of things that I've seen that have been different about this story, and I alluded to it at the beginning. One is that we have a clearer articulation of role delineation. So as these organizations are just in discussion, they're saying to themselves, which one of us actually can contribute value in what areas? Where do we need to be together on these? And in what instances can we converge the value chain to deliver a more unified consumer experience? Now, that last statement I say is just starting to happen. It's more about we're going to do the kind of high-level care management for the bottom of the pyramid. We're going to make sure we don't just bolt on care management resources, but we're going to deploy those inside the primary care practices because that's where they actually have a greater effect. We're going to think about the pricing model together. So it's not as kind of dandy as I'm describing it, but at least that conversation's happening, and I think it's awfully important. The other thing is, as a payer and a provider, when you come together, you're not necessarily thinking about a monolithic population, right? So if you were to come together with a co-branded product or a JV product, are you going after everyone or are you targeting? And we've seen some interesting models emerge that are more targeting. So in this story here, this would be going after perhaps a millennial population where you're saying, well, what matters to that population, right? It's ease, it's simplicity. It may not be a very warm, tight relationship with your primary care clinician. It might be about creating a network around telehealth and urgent care and your retail clinics. So architecting that story against a specific population and understanding their behavior and their hassles is something we've seen to start to emerge that actually is a bit different. And then I'm not going to spend a lot of time here, but I had some fun with some providers and payers recently thinking about, well, what would be very different, right? And I'm hoping these attributes start to emerge inside of the model, right? Can we actually get to a point where we're not just ramping down price, but we're doing things like neutral or multi-year trend guarantees? Work together to actually say over a 3-year period, we're going to rein in total cost of care and actually bend trend. Can we actually stop dealing with the process? Can we just make that much more hassle-free and not have to go through approvals at every turn? Right, so from an integrated population health management standpoint, can you actually start to leverage machine learning to get and integrate your claims in your clinical platform to get greater insight? So yes, we have insights in terms of gaps in care, but can we actually have a step change in terms of the learning on that based upon scale? So there are attributes that I think are different. The access one we talked about. The one on the bottom left, I think, is a next evolution of where healthcare needs to go in general, which is around transparency, understanding budget, understanding financials, understanding wait times, and actually working as a payer and provider to provide that experience in a more deliberate way. One example that I recently came across, we have a health innovation summit every year, was between Mount Sinai and Oscar. Oscar is a startup health plan, as most people are probably aware, in New York. One of the founders happens to be one of the Kushner sons, but we'll leave that aside. But they've done some really interesting things. And Mount Sinai is the largest AMC. It's the largest hospital system in New York City, right? So why would a large hospital system and a startup payer come together? And they had a different end game vision, right? That end game vision was, we are going to revolutionize the member experience from the time of enrollment all the way through to the time of activation, to scheduling, to care delivery. It is going to feel completely different, right? A few things that they did that also felt different. They had collaborative design of their model. So they actually, at the very start, said, what is the pricing model? We're going to allow the provider into that kind of payer side of the value chain. What is the pricing model going to look like? How are we going to think about the financial model together? They created a joint financial model and a joint dashboard, right? That starts to feel pretty different. They had their senior executives at the table, not at the beginning, but through the process to break down barriers. They have actually created a joint retail clinic in Brooklyn, right? That's feeling very different. It's payer-provider-led retail clinic. They hardwired demand, so they said, you know what, to make sure we actually get traction early, we're going to pay for slots for Oscar members to make sure that, to ensure we can get some bolus of confidence on the provider side that this actually makes sense. They thought about member transitions, right? If you're going to kind of disrupt the physician relationship and kind of go narrow and have patients need to choose a Sinai doc, how are you going to carefully articulate that to the patient? And they had brand humility. There were some times where the payer needed a lead, there were some times where the system needed a lead, and sometimes they had to do it together. This is a very different type of partnership model. All right, I'm going to quickly buzz through this and finish with some predictions. First, we've been tracking how prevalent some of these kind of second wave or next generation of partnerships are. We actually have had over the last 4 years about 200 or so of these partnerships, right? That's not immaterial. And California, congratulations, you're leading the market again. But just in 2016 alone, we had Aetna and Providence, Oscar and Providence, St. Joe's and Cigna, and I'm probably missing a few, but we're starting to see this occur not just kind of in California land, but across the country. The connection between the two sides is actually becoming deeper. So 4 years ago or 3 years ago, when you looked at how many of those partnerships were co-branded, 22%. If you look at where they are, at least in the 20 or so that have been released this year, almost 3/4, right, have been co-branded or JV'd, which is a much deeper level of connection. And whereas a few years ago there was not as an explicit mention of value, we now have a much more explicit mention of value as part of that partnership. Local dynamics are going to matter. I won't be able to spend time here, but how the membership and the lives distribute and how much is commercial versus government kind of goes back to that cross-subsidization question. And are you in a market structure that's fragmented on the payer side and the provider side or consolidated? Affects a lot of behavior. And you tend to see more innovative partnerships emerge when you have a more fragmented environment for the reasons we talked about, that Michael talked about. So a few predictions, which are always scary, but let's give it a go. I think over the next few years, we're going to see a regional dance emerge, right? So we are going to see competition where providers and payers are picking sides that are going to go to market together, right? You're going to see instances where a Blue is going to pick a side with a certain health system. You're going to see a national pick a side with another or a network. And we're going to see a battle emerge that is different than just provider against provider or payer against payer. It's going to be a combination. I think we're going to start to see a new dance. I think we're going to see the continued advancement of those deeper partnerships. Because of that macroeconomic and affordability issue, we have to. I think we have to. And value-based contracts have been hard. It's a lot easier to share savings when you're doing it for the right reasons together. I think we're going to see a continued kind of pendulum swinging towards private market leading value-based care innovation. I really hope the government continues to kind of push on this, but we'll see. I think employers are a missing part of the story. I think employers are going to get the attention of providers and payers together, and they're going to go to market with employer solutions. I'd like to believe that employers are going to avoid disruption or going to stop avoiding disruption, but I think they will. I think the broad PPO model will continue to exist. And then, in the last few, we're going to have some implosions. I do wonder whether we're going to see kind of more virtualized Kaiser-like models emerge. I think that is probably on the horizon and have a pretty big impact. And then the last two I'm intrigued by. I wonder what portions of that value chain are going to get carved out by players that are not in front of us, who don't necessarily need the clinic, who don't necessarily need that kind of risk model and can go direct to consumer and create a population health model directly around an individual or an insurance model directly around an individual. And we have an interesting few years ahead of us, but I look forward to hearing from the next presenter and happy to answer any questions afterwards.